This is the host to Ms. Bowery. Could you please give us a mic and video check when you have a moment, please?
Take a look at HR 38.
Good morning, can you hear me now?
We can hear and see you clearly. Thank you very much. This is the host. I'm going to restart recording now, so please do a 10-second mental countdown, and then we can resume.
Good morning. My name is Stephanie Donaldson, and I'm the Vice Chair of the Board of Health. The Board Secretary has confirmed that we have quorum, so I'll call meeting 38 of the Board of Health to order. Welcome, everyone. Today's meeting is being held with board members and city staff participating both by video conference and in person at City Hall in Committee Room 1. City Hall is open to the public and anyone is welcome to attend the meeting at City Hall today, and the public may continue to participate electronically via video conference. This meeting is also being live streamed online at youtube.com/Toronto City Council Live. I ask everyone for their patience with any delays and technical issues, including the last few minutes. The clerks will connect all registered public speakers to the meeting via audio. The list of speakers can be viewed online by visiting the Board of Health's page at toronto.ca/council and clicking the speakers box for today's meeting. The Board Secretary has also emailed the speakers list to all directors. Directors, this is a paperless meeting, and the Board Secretary has provided all agenda materials on toronto.ca/council and via CMP, which is the clerk's meeting portal. Directors, for those of you online, can you please keep your mic muted unless you wish to question staff or speak to an item, and ensure that your video is turned on. And as part of each agenda item, I'll ask directors to raise their hand or unmute their mic if they wish to question staff or speak. I'll then create a speakers list, and we'll call on directors when it's their turn to speak. And when voting on an item or a motion, I ask that directors ensure that they turn on their video and to raise their hand to indicate their vote. Directors, I want to remind you that you must submit and approve your motions by email. Staff are available at boh@toronto.ca to help with motions. And I will now ask Director Peter Wong to provide the land acknowledgement statement for today's board meeting. Over to you, Director Wong. Thanks in advance.
Thank you, Chair Donaldson. As we meet today on this hybrid platform, the good mind tells us that we would like to begin by acknowledging Indigenous peoples of all the lands that we call home. This land acknowledgement is an expression of the gratitude for the land, and one that has been practiced long before European settlers arrived on Turtle Island, also called North America. The land from an Indigenous perspective has a much larger concept, a concept that describes the interconnected relationships between physical environment, biological organisms, the atmosphere, and in the case of Indigenous worldview, also the spiritual realm. The land is not just inanimate objects of rocks, minerals, and water. The land has its own agency, spirit, and rights that are to be respected. So as we approach National Indigenous Peoples Day, let us continue to learn more about the rich and diverse culture and learnings of our First Nations, Inuit, and Métis peoples. And as settlers in Toronto, let us recognize that the land we are meeting on is the traditional territory of the many nations, including the Mississaugas of the Credit, the Ashtanobec, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 and the Mississaugas of the Credit. Meg Chair Donaldson.
Miigwech, thanks for helping us start in a good way, Director Wong. Are there any declarations of interest under the Municipal Conflict of Interest Act? And if you have an interest, please raise your hand or unmute your mic and indicate the item number and the nature of the interest. All right. Just checking the screen and seeing none. Next, we need a motion to confirm the minutes from our last board meeting on May 16th, 2022. Can I get a motion? Director Fillion, I have a motion from him. All those in favor? Great, that motion carries. Thank you. So before we proceed with the agenda, I'd like to introduce the following item of new business. It's appointments to fill committee vacancies. And I will ask the board secretary to display the item so that directors can review it before voting on whether or not to add it to the agenda. Thanks very much. It's just being displayed now. And the recommendation is... That looks good. Oh, I should have worn my glasses. The Board of Health appoint Director Joe Mihevik to the Board of Health Performance Appraisal. Oh, wait, sorry, we're not voting on this now, right?
Yeah.
I apologize. We're just adding the motion to the agenda as new business. So can I see any hands for all those in favor of adding this item to the agenda as new business? I can't really see. Okay. I see a lot of hands on the screen, so that motion carries, and the new business item is item HL 38.6. So we'll hold this item down so that the board secretary can make the item public online and on CMP, the clerk's meeting portal, before we consider it in further detail later during this meeting. Okay, so that brings us to the first item on the agenda today, and it's the election of the Board of Health Chair. It's HL 38.1, election of chair for 2022. And at this point, I'll ask the board secretary to conduct the election of the chair. Thank you, board secretary.
You're welcome. Directors, I will conduct the election of the chair, but first there is a registered speaker, so I will call Derek Moran to speak.
I just want to say about me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied. In doing so, it's fraud. God bless Her Majesty the Queen, and long live Her Majesty the Queen. And let the record show that I do not consent to the warrantless searches taking place downstairs here at Toronto City Hall. So, you know, being back here for the first time in like 2 years, it brings back memories. It also brings back memories of how I was gently assaulted by City Hall security 2 months ago when I showed up here thinking that Mayor Tory said we're back to in-person meetings, and I was ushered out of the room here. But interestingly enough, 1 month later, candidate for mayor Chris Langenfeld last month came here, sat here and gave his 5-minute presentation. No problem. So I guess that's just the arbitrary nature of the city of Toronto there. So I remember Joe Cressy's last meeting, he mentioned to you, Chair Donaldson, that you'll be assuming the duties of the chair and assuming the duties until the next chair is chosen. And it got me thinking of something that was said at the last term of council by, oh, here we go, just as I thought. Thing's not working. Okay, so this is a screenshot of, Mayor Tory was trying to school Councillor Janet Davis at the time on fiduciary duties, and he's just starting off by repeating something that he said back. She said back to her, "There's a fiduciary duty involved in being on this board." Well, there's a fiduciary duty involved in being on all of the boards to which we appoint people, and to me, there is no distinction from one to another, and that the responsibility that rests at common law and as well as under all of our codes and procedures to respect that fiduciary duty and to conduct oneself in the way we're expected to do here. So for whoever's going to be the next chair, I just want to speak a bit on duties. My money is on Councillor Havoc here. So this is from Friends of Point Pleasant Park versus the Attorney General of Canada 2000, where the federal court said, they're quoting I think a Court of Appeal case from BC, where the municipality was found to owe a duty to the public to provide full disclosure of information. this is some numbered company, Ontario Limited versus Garay, 1997. Ontario Superior Court said, a trustee is a fiduciary. All of the obligations imposed by the courts of equity upon fiduciary also apply to trustees. A trustee is required to act in a selfless manner for the sole benefit of the beneficiary. The trustee is prevented from preferring his or her own self-interest or the interest of any third party to that of the beneficiary. The trustee must make full disclosure to the beneficiary of all material facts. This is from Rhodey and the City of Halifax, 1974, Nova Scotia Supreme Court. Because the council is in fact a trustee of the inhabitants of the community, and a cestui trust is always permitted to question the administration of the trust by the trustee. That was declared in the same case of Bose versus the City of Toronto. This is from McElwraith versus Hart, 1908, Supreme Court of Canada. The right of the inhabitants to compel the city corporation, that is the city council, as a body to do its duty rests on this, that the corporation is a trustee for the inhabitants. That was declared in the same case of Bose versus City of Toronto. The city council was in effect, in substance, a body of trustees for the inhabitants of Toronto. This is from Toronto Party for a Better City versus the City of Toronto, 2011 Ontario Superior Court. This one's pretty long, but the one point I wanted to point out was where it said, court said, trustees have a considerable extent of discretion and power, but also having duties to perform and forbidden to act corruptly. This is JN versus CG 2022, Ontario Superior Court. When did it become illegal to ask questions? Because when society demonizes and punishes anyone who disagrees or even dares to ask really important questions, the resulting polarization and disrespect and simmering anger can have devastating consequences. No one is a bad citizen simply by virtue of asking questions of the government. And this one is from Allstate Insurance of Canada versus the City of Toronto, 2001, Ontario Court of Appeal. Said the application judge noted that those core values as articulated by Judge LaForest are those involved in the search for political, artistic, and scientific truth, the protection of individual autonomy and self-development, and the promotion of public participation.
Your time is up, Derek Moran.
In the democratic process.
Thank you.
Hey, isn't that the chair's job? I've never heard Julie say that.
Okay, we'll proceed with the chair election. Members, are there any nominations for chair of the Board of Health? I recognize Stephanie Trustee Donaldson.
Thanks. I'd like to nominate Joe Mahavik.
I am calling for nominations a second time. Are there any further nominations for chair? I am calling for nominations a third and final time. Are there any further nominations for chair? Hearing no further nominations, I declare that the nominations are now closed. As Director Mahavik is the only nominee, I declare him the chair for a term of office starting June 20th, 2022 and ending on November 14th, 2022.
I just want to make a few comments just as we start this, recognizing this moment. I'm proud and glad, and with a certain sense of a civic duty that I'm here. I want to, looking backwards, I am so thankful to Councillor Cressy for all the work that he did in the last several years to you, Stephanie Donaldson, for vice chairing and for filling in this last little while. To good folks in Councillor Cressy's office, now my office, Brent Gilliard in particular, for helping steer the public health ship of state. I am really proud to be once again part of public health. I've always thought in my 27 years or so, during which time it was either John Fillion or I who were the chairs of health, that public health did such good work in our community. And especially during this COVID period, I have felt that you have really conducted yourself, I'm speaking now specifically to public health folks, with a great amount of courage, insight, and nonpartisanship. Courage, sometimes you took it in the chin from certain members of the public, and you took it because it was part of your civic duty. With insight, really being smart and targeting, especially vulnerable communities in Toronto, and making sure that we did, as a city, double our efforts to make sure that those people got the attention that was required. And nonpartisanship, I didn't sense, at least as observing as a member of the public, that there was this traditional partisanship that we sometimes have. We always see, frankly, here at Council. We were in the middle of an emergency, and people conducted themselves so well. And the result of this, and this much I did study because I taught some of this in these courses that I taught, we were really in Toronto top of class in so many categories relative to other big cities. Our vaccination rates are top of class, top 10 if not top 5. Burden of illness, we have a lower burden of illness than many cities across the globe. The death rate also lower than most cities around the world. And especially in the area of outreach to hard-to-reach residents, that was second to none. And I'm here for a short time. I'm here for a good time. I hope to continue that good tradition that folks have established here. And I look forward to working with you, Julie, in the clerk's office, with the Board of Health folks, Dr. Davila, and with the mayor and council and other orders of government to continue the good work that folks have been doing. So with that said, we can go through the agenda and hold down items that we want held down. Number 1 has been dealt with, election of chair. Number 2 is an update on COVID-19 response and other public health functions. There's a presentation from Dr. Davila, so we'll hold for presentation, and we also have a deputation there. There are 2 deputations for the next item and also a presentation for the Toronto Overdose Action Plan Status Report 2002. We have, so we'll hold that down. HL 38.4, service agreements awarded and executed by the Medical Officer of Health for 2022. There are no deputants, so we can deal with that quickly if there is such a mover. Trustee Donaldson, any debate or discussion? No, seeing none, all in favor, opposed if any, that's carried. HL 38.5, 2022 Toronto Urban Health Fund Review Process and Allocations. There's a staff report with recommendations. There are no deputants. Moved by Councillor Robin Buxton-Potts. Does that work? Yes, okay. All in favor, opposed if any, that is carried. There are 2 other items. One has been introduced. That is the appointments to the subcommittee. Is it ready to go? Does anyone need to read it? Basically, it puts me in the places where Councillor Cressy was before. Do you want to display it? Okay, let's display it. Yep. This is item 6. Okay, I'll give folks maybe 10 seconds to read it. Does anyone want to hold it for any purpose? Okay, moved by Dr. Peter Wong. All in favor? Opposed, if any? That's carried. There is another item from Councillor Robin Buxton Potts. I know that people have not seen that because that was only introduced or given to the clerk's table a few minutes ago. So we'll just introduce it. It has to do with requesting a report at the next meeting, which will be in early 2023 around mental health. But let's hold that for a second. We'll deal with it to give people a chance to read it. Okay, so we'll go to the top of the list. And the first item is the update on COVID-19 response and other public health functions through the magic of the IT staff. Dr. Davila will be doing this from home. There you are, Dr. Davila. You look healthy despite having had a COVID weekend. I hope you can report on that. And of course, we were sending you all the best vibes that we could this last weekend. So over to you for an update on COVID-19 response and other public health functions. Dr. Davila.
Great. Thank you, Mr. Chair, and welcome back to the chair's seat. Congratulations. And yes, I am feeling reasonably well. You might hear my voice isn't exactly as per normal, but I shall do my very best to see you through this presentation with hopefully not too much trouble from my voice at this point in time. So good morning, members of the board. I am pleased to bring you this presentation in respect of the report that you have in front of you today. And in particular, we're going to focus at the outset on our response to COVID-19, as is our usual practice and has been for several months now. I will thank my colleague Bree for driving the slides, and let's move on to the next couple of slides so we can dive right into the presentation. And as per usual, we're starting off with an update on where we are in the pandemic. So this is a site that is familiar to members of the board. This is the monitoring dashboard in its latest iteration. As you can see here, we are seeing general improvement overall when it comes to the key COVID-19 metrics. 7-day moving average on new COVID-19 cases is currently sitting at 165. And just by way of reference and context, when you last saw this dashboard last month, that figure was sitting at 392. Weekly incidence rate for new COVID-19 cases is now sitting at 42 per 100,000. The last time you would have seen this, it was sitting at 97. And daily COVID-19 outbreaks, active daily COVID-19 outbreaks in institutions currently sitting at 25. The last time you would have seen this presentation, it was sitting at 74. So you can see that overall things are generally improving, and our most current wastewater surveillance data suggests that the levels there are holding stable, and you can see that at the bottom of this slide. Moving to the next slide, we have the other half, if you will, of the dashboard. And it also shows that whether we're looking at the severity measures, and the vaccination measures, we're seeing just general improvement overall. When it comes to those severity measures, you can see that we are now experiencing new hospitalizations, with a 7-day moving average at 4 a day. The last time you saw this, it was sitting at 7, new ICU admissions less than 1, and we are slowly but surely continuing to see increases in respect of vaccination over time. So these data are, of course, always available to you through the monitoring dashboard, which is accessible through our website. On to the next slide. And as we think about moving from looking at the most recent data, the most current data, and what specifically has been going on in the last couple of weeks, to a general observation on the pandemic overall. And when we take that big picture view, what emerges overall as we look at the course of the entire COVID-19 pandemic to date is that there is a clear value to vaccination. There is a clear value to using the layers of protection over and above vaccination, and that there has been clear value related to the extensive efforts of public health staff and our partners in terms of mitigating the impact of COVID-19 on Torontonians. And over the next couple of slides, I'll walk you through how this is actually borne out in our data and in our local experience. So if we can go to the next slide, what you'll see here is a depiction that actually shows the case, hospitalization, and mortality rates per 100,000 population by age group for the entire pandemic. And while you can see that clearly cases were seen across all the different age groups, we know that the highest hospitalization rates and mortality rates were actually experienced by older adults, particularly those over the age of 70. This was the group that had the most by way of the severe impacts associated with COVID-19. No question about that. Moving to the next slide, we get a slightly different view of our data. And here what you see are all institutional outbreak cases over 70 years of age. And it's by severity, where you have the not severe depicted in the pale orange and the severe cases depicted in the darker orange. And these are done by episode date. And you can see that it's split out with the various waves depicted in this graph. And just to be clear, when we're talking about severe cases, we're talking about those that resulted in hospitalization, ICU admission, intubation, or unfortunately death. And as depicted in this graph, you can see over time, as widespread vaccination became part and parcel of our environment, you can see that the severe outcomes amongst those who were 70 plus in institutional settings and associated with outbreaks decreased over the time that we began to see more and more vaccination uptake. Yes, within long-term care and the institutions themselves, but more broadly across the entire community. And that's depicted by, you can see over the course of the waves, the components of the graph that are in that darker orange color is clearly decreased, even as cases increase. You can see this particularly in waves 5 and 6. Next slide, one more depiction using, again, our local data. Here you can see the incidence of mortality in this graph amongst people aged 80 years of age and older. This does not include outbreak cases, as did the last graph. But this does look at those 80 years of age and older in the community and as well within long-term care. And what you can see here is clearly mortality improving, a significant improvement, particularly amongst those residing in long-term care homes once a vaccine was more widespreadly available and taken up by an increasing proportion of the population. Again, you can see the blue line tracing those deaths amongst long-term care residents, not reaching as high peaks as they did in earlier components of the pandemic course. And again, nicely depicted here for us in this graph. So next slide. What can we take away from all this? We know that seniors are clearly those who take on more of the severe impact. They experience more of the burden of illness and the severe illness in particular associated with disease. And what we can see here is that there are ways to protect them, and it requires a multi-pronged effort, and it should continue to be, and it will continue to be for us a priority. So this is just to give you a flavor of that which we are doing in collaboration with our key partners to ensure that this multi-pronged effort continues, particularly while the pandemic continues. So when it comes to long-term care homes, particularly around infection prevention and control, this is one of the major benefits outside of that which is provided by vaccine. We have improved collaboration amongst the different partners, and I think what we're seeing is that that effort is really paying off in terms of better infection prevention and control protocols, and we're actually getting the outcomes associated with that. less by way of illness and more severe outcomes associated with illness that enters within the long-term care setting. We have a number of testing programs. We're facilitating access to early treatment. This over and above vaccination, it's this combination of all the efforts and the collaboration that exists between all the necessary stakeholders that I think has really made a difference within the context of long-term care. For community dwelling seniors, our focus is on working with our partners, and you've heard about this at a number of different meetings, around improving vaccination accessibility. The most current examples that I have to offer you at this point in the pandemic is that we are continuing to see good success with mobile clinics in naturally occurring retirement communities, whether we're talking about seniors buildings that are part of the Toronto Community Housing portfolio, or other buildings that we know are more typical of naturally occurring retirement communities where there are a number of seniors. We know that when we work with our community partners and have forays into those communities, advising people that we are going to come with a vaccine and what the benefits of receiving that vaccine might be, we're seeing that when we host mobile clinics in those communities and settings, that the uptake is actually quite strong. And we're pleased to see that people are continuing to get the protective benefit of vaccine as a result. Next slide. In this next component of the presentation, we're going to be focusing a little bit more on COVID vaccine and the public health guidance. And as remarked upon already by Chair Mihevc, we are, again, I would say, experiencing really remarkable vaccination uptake and coverage against COVID-19. This continues to be one of the things that I still find absolutely remarkable, that we are at this point in time. Back in 2019, we never would have believed that we could actually get to this point. It's just never been seen with a vaccination campaign ever before. 92.1% of Toronto residents age 12 plus with at least one dose on board, just shy of 90, 89.6 of that same population with now 2 doses on board. We are continuing, of course, our efforts on vaccination when it comes to our younger members of our community, those aged 5 to 11. We now have just shy of 60% of that population with 1 dose on board and 45% with 2 doses on board. And of course, our efforts are continuing as we wish to increase the vaccination coverage in this population so that they can benefit from the protection of vaccine. And finally, over 70% of individuals now age 60 plus have received a 3rd dose, 27% have received a 4th dose. And as you can see from the earlier data that I've presented already, that it is important that those who are 60 plus years of age really take advantage of the protective benefit of vaccine. We know it makes a difference in respect of reducing their likelihood of severe outcomes associated with a COVID-19 infection. And so that is a priority and continues to be an area of focus for us, driving vaccination coverage, ensuring that those who are at highest risk of severe outcomes associated with a COVID-19 vaccine are afforded every opportunity to avail themselves of the protective benefit of vaccine. Next slide. I think this just speaks a little bit further to that which I've been saying, that we are continuing to recommend that individuals get the doses that they're eligible for. This is not a recommendation that is unique to Toronto Public Health. In fact, we are seeing that public health officials the world over are, advising exactly the same for the populations for which they have responsibility. And in keeping with that, we are continuing to work on ensuring access, really maximizing access to the vaccine as much as possible through our hyper-local, equity-focused vaccination campaign. We are also, of course, working proactively on planning for vaccination against COVID-19 for children aged 6 months to 4 years. Number of conversations and active planning happening with our partners, and we are consulting with parents in order to develop a needs-based approach that is actually respectful of the reality of the lives of parents and families that have children in this age group. I'm sure members of the board will have seen that in the United States, the vaccination products for this age group, this youngest amongst us, has been approved. Again, Canada does have a different process. We are in active conversation with our partners, and we certainly have every intention of being ready to support this campaign in the way that makes the most sense, so that the protective benefit of vaccine can be provided to this youngest segment of our population, recognizing that it has to make sense to the parents and be respectful of the reality of their daily lives. So this is still a work in progress. We are actively working and surveying parents so that we can ensure that our planning efforts actually meet their expectations as much as we can and are respectful of the realities of their daily lives. Next slide. We are at the same time, of course, planning for the upcoming fall season. Many of you might have heard the remarks made by the Chief Medical Officer of Health a little over a week ago now. He was making some observations in respect of, what might be coming down in terms of the fall, talking about, vaccination efforts for COVID-19, which may include more specific boosters, Omicron-specific boosters, for example. This is the kind of thing that we're actively planning on. And so what this means is making sure that we're keeping our communications channels open, both with respect with our planning partners, but as well with the public that we serve. We know that the province is expanding its live calling efforts. Our local data suggests that we are best off to engage in complementary approaches. If the province is going to take on the role of live calling those who would benefit most from receiving vaccine, we have looked at our data and consulted with our public and recognize that where we can have the greatest effect and the way we can have the greatest synergy with the efforts of the province is to continue our approaches to increase confidence in and access to the COVID-19 vaccine. So this involves using our community partners to help address questions and concerns that people may have, trusted members of the community who can have honest conversation around the benefits of vaccine with local members of their community, and as well from our perspective, ensuring that we're making vaccine as readily accessible to people as we can possibly do. We are also working with key sectors to plan for the fall. As I've mentioned earlier, we talked a little bit about the kind of benefit we've seen as a result of the collaboration with those who provide care within institutional settings, long-term care homes, retirement homes, transitional housing, hospitals. We are actively working with these partners to ensure that they are ready, that they're getting ready for what may be a very busy viral respiratory season, and really trying to capitalize on the lessons we've learned thus far over the course of the pandemic. Next slide. Just a reminder as to what actions have been taken by our provincial counterparts as of late. Just last week, the province did lift most remaining masking requirements. Masking does remain mandatory in certain settings, long-term care homes and retirement homes and shelters, and as well on the Wheel-Trans service of the TTC. And, this is an opportune moment, of course, for me to remind the members of the board and the broader public that masking is and continues to be important. If you have symptoms of COVID-19, if you're recovering from COVID-19, if you're a close contact of somebody with COVID-19 or close contact of somebody with symptoms, we are actively encouraging that even though masks are not necessary in many, many contexts around the province, that there are still moments where it makes sense, particularly for those of us in the community that are at higher risk for acquiring COVID-19 or at higher risk for more severe outcomes or live with somebody who is in these circumstances. So lots of information and advice, I should say, is available on our website. We know that masking makes a difference. And for those who are interested in reading more about this and understanding more about that, I would refer them absolutely to our website, where there is a wealth of resources available for perusal. Next slide, please. I think that takes us to, just some general advice around enjoying a safer summer. We're just teetering on the edge of summer. I think it officially begins first thing tomorrow morning. And this is an opportunity, I think, for people to really enjoy what is just far too short a season generally here in the city. This is an opportunity for people to absolutely take advantage of warmer weather. It is certainly easier to get out and about. And from a COVID perspective, it is safer to be able to socialize and visit and to do all the activities that make life much more fun and that allow us to have interaction with our family and friends and loved ones in an outdoor environment. Of course, we would be remiss if we didn't remind people that COVID-19 isn't the only thing you need to consider. We do need to think about exposure to sun and UV light, to making sure that people are staying hydrated, and of course, to protect oneself from the bugs that are out there. So sunscreen, hat, water, and bug repellent are going to be the kinds of things that you might want to consider in terms of protecting yourself overall. Again, reminders around mask use and when it's especially important, indoors in crowded settings. If you find yourself indoors with groups of other people, wherever possible, opening windows to improve ventilation does make a difference. A reminder to people to stay home if you're feeling sick, even if your symptoms are mild. And as you can see, I am trying to heed our own advice as much as I can. And finally, just an opportunity, and we are putting this out to our public, that this time of year does offer that opportunity perhaps to get caught up with routine health checks and with all the other vaccinations. Absolutely, COVID-19 vaccines for which people are eligible, they should take full advantage of those. But of course, there are other vaccines that are important parts of preventative health measures. And so we would just remind people to think about those opportunities and to try to take advantage of the warmer weather to get some of those things done. On a more personal note, it wasn't that long ago, just a few months ago, that I underwent treatment for a condition that was actually found on routine screening. So again, I can't emphasize enough how important it is for people to make sure that they're looking after their whole health as much as possible. And, I recognize that this isn't always easy, but every step that we take towards that is a step in the right direction. Next slide. In the report that's in front of you today, we also talk a little bit about other public health priorities outside of COVID-19. I know that for the past 2.5 years, public health and COVID-19 response may have seemed somewhat synonymous. But of course, members of the board will know that COVID-19 isn't the only thing that we do in public health. So over the course of the last 2.5 years, we've done our best to maintain what we could of non-COVID-19 work, despite the very, very heavy load of COVID-19 response. And as things ease a little bit, as we see more improvement in COVID-19 indicators, we are afforded the opportunity to turn our attention to other pressing health issues that actually impact on the health of Torontonians. And we are doing this with the core objectives of public health in mind, and with the guiding principles as articulated here on this slide. And just to refresh the memories of the members of the Board of Health and to put this in the minds of the public that we serve, public health's goals are to maintain and improve the health status of Torontonians, to do what we can to reduce inequities in that health status amongst Torontonians, to prepare for and respond effectively to outbreaks and public health emergencies. And we do those goals, we seek to achieve those goals with the guiding principles of always using evidence, to support the best decision making and the courses of action that we will pursue. That we prioritize those interventions that not only improve overall public health, but as well reduce inequities in health status. Again, that's a key objective for us. And then finally, we think always about public health as a public good, in that it serves and benefits all members of society. And we recognize that part and parcel of that is ensuring that we keep an open and transparent dialogue with the public, and that we always have the public in mind, that we are accountable to the public that we serve, and that we're constantly thinking about their health status, the inequities in the health status, and how best we address those issues. That's first and foremost. So these are the guiding principles that we have used to help inform and anchor our discussions at Toronto Public Health. So turning to the next slide, it's with those goals and principles in mind that we have, as is our obligation, constantly reviewed current population health evidence, including our local data. And on the basis of the available evidence that's available locally, the data that we see, plus that which we see in the literature, we've identified the following short-term priorities to see us through the next little while as we're continuing to respond to COVID-19. So as you can see here, first and foremost, it's that continued response to COVID-19 and using that, that response and all the lessons we've acquired along the way to support the overall organizational readiness for other emerging public health issues. We'll have a little bit more on this in just in the next couple of slides, but this is to give you a high-level summary. We also are looking at focusing our resources wherever possible to responding to the drug poisoning epidemic. I'll have a little bit more again on this as well, promoting mental health and rebuilding public health functions. So let's just dive into these in a little greater detail so that the board has a sense as to what it is we're talking about when we talk about these short-term priorities. This is, of course, articulated in the report, but I think helpful for you to have a little bit of more of a flavor and some discussion around this. So next slide. Focusing on addressing emerging public health issues. So what's interesting, and I'm sure has not gone unnoticed by members of the board, is that yes, there has been, thankfully, some decline locally in respect of COVID-19 activity. But interestingly, there has been a resurgence and some increased activity in other communicable diseases. In fact, this spring we saw a rather late increase in influenza activity, not something that we haven't really seen before. And I know that those of you around the board table who work in clinical settings are probably quite familiar with this. And as well, we are seeing, increased activity beyond what has been the standard geographic location of other diseases, most notably and certainly in the news, monkeypox. So we are continuing with our COVID-19 response, but of course, managing these other communicable diseases that have emerged on the scene and applying the best practices and lessons we've learned in responding to these new challenges. And I think it's important that you have a sense that this is exactly what is happening here at TPH. To the next slide, just a little bit more by way of monkeypox. This gives you a sense as to what the most current data are in terms of the geographic distribution of monkeypox cases. This is as of June 17th. You can see that while the most significant concentration is in Western Europe, we are right now certainly the top 6 within the top 6 of non-endemic countries that are actually seeing monkeypox cases. And the next slide gives you a little bit more of a sense as to that which is happening locally. We did have our first case reported towards the end of May, and as of the 17th of June, we have 51 cases under investigation, 26 of which are confirmed, 5 are probable, and 20 suspect. They are largely male, and the most significant risk factor that's been reported amongst our cases is having men who have sex with other men. And we have seen a number of confirmed and probable cases having frequented a Toronto bathhouse in the relevant time period. So this gives you a flavor as to what is being investigated and the kind of work that's being undertaken by our colleagues here at Toronto Public Health. Next slide. There is active conversation and work and collaboration that's happening between ourselves, our provincial partners, and our federal partners as well. Just towards the end of last week, the province designated monkeypox a disease of public health significance, meaning that cases must now be reported to local public health. Prior to this, they were going through a slightly different route where they went to a provincial agency, Public Health Ontario, and then eventually made their way to local public health. This, I think, is a more efficient mechanism for reporting. But that being said, regardless of the reporting mechanism, we are undertaking a very significant effort to mitigate the impact of monkeypox in Toronto. We have staff conducting case and contact management. We have vaccination clinics that are happening. And in particular, we're focusing on those individuals who are at greatest risk of exposure. And we are working with a number of partners on education and outreach efforts. Our community partners associated with this have been second to none, I think is the easiest way for me to describe it. They have been incredible supports, and we look forward to our ongoing and continued collaboration with them as we seek to limit the impact, the negative impact of monkeypox on Torontonians and others who might be visiting the city. Next slide. This takes us to the next short-term priority articulated in the report. There will be more on this. We have another presentation coming up and another report in respect of the Toronto Overdose Action Plan and the actions we are taking in respect of the drug poisoning epidemic that is affecting our city. Suffice it to say for now that it is a worsening situation and one for which we must continue to do our very best to prevent these preventable deaths that are happening and to really aim to optimize the health of people who use drugs in our community. Next slide. This gives you a summary of the kinds of actions that have been undertaken to date and are continuing to take place in order to address that drug poisoning epidemic. Again, more on this in the next presentation I have for the board. I'll move on to the next slide, which speaks to our short-term priority in terms of promoting mental health. We know, and I'm sure you have seen both through reports that we've brought here and through reports that are seen in the popular press, that the COVID-19 pandemic has certainly had a negative impact on the mental health and well-being of all of us. Whether we're talking at the individual level, at the community level, at the family level, it has been a very significant burden, in terms of mental health that COVID-19 has put on our community. We are seeing people reporting stress and anxiety. We've seen children and youth who've been impacted by school closures and interruptions. We know that the Toronto District School Board has, undertaken assessments of their students. You can see here that in general, in the midst of the pandemic, we saw students being, just unhappy, less happy, with reporting more loneliness and stress and feeling nervous. And we know that there are a number of different subpopulations through various surveys and studies that have experienced and reported more anxiety and more depression during the COVID pandemic compared to pre-pandemic, pre-COVID times. Next slide. We are also seeing an increase in mental health service utilization. And again, for those of you around the table who are engaged in clinical activity, I know you are seeing this and probably hearing this from your colleagues. Whether we're talking about an increase in outpatient visits for mental health care or, what's happening in emergency departments, these are the kinds of things that we're seeing and have been reported throughout the course of the pandemic. Turning to the next slide, this provides you with, again, one little glimpse into the data that we have access to courtesy of other partners. This talks about overall suicide ideation in in Ontario, excuse me. You know, taking a look at the reports from Ontarians in 2019 versus that which was reported in the fall of 2020. And you can see that there was a statistically significant increase in overall suicide ideation in Ontario amongst those aged 18 to 29 and 40 to 49. So this clearly, again, is just a little bit of an insight for members of the board in respect of what's being experienced from the mental health perspective. So with that, you know, what are we doing? Next slide. We have a number of key actions that we're proposing to promote mental health. I would be very remiss if I weren't to mention to the board that, of course, as Toronto Public Health, we don't directly deliver mental health care. That's actually in the purview of our healthcare partners. We do, however, collaborate significantly with partners on strategies and actions to help promote mental health and well-being at the population level. So again, without going through every imaginable thing that we could talk about, this slide captures at a very high level the kinds of work we are doing. We know that our healthcare partners have indicated that mental health and substance use are amongst their top 5 priority areas that they're looking at. So we see our role in helping to augment that and to connect the various parts of the system for more optimal care. So what this might look like on a very practical basis will have to do with things like collating and reporting on mental health data and evidence on what actually works, particularly at the population level. We are working towards contributing to a post-pandemic, when we finally reach that happy day, mental health strategy for implementation by a broad range of partners. This is not a single agency kind of undertaking. And certainly we're working with our partners to improve access to mental health resources. This includes mental health care. And we do this not only with our healthcare partners with whom we've developed, I would say, a very deep relationship over the course of the last 2.5 years, but as well with other city divisions and with other community organizations, again, with whom our relationship has deepened over the last couple of years. We are also focusing on integrating mental health promotion into a wide variety of Toronto Public Health programs and services. Whether we're talking about the work that we do within schools or with new parents, there are many opportunities for us to integrate more mental health promotion into our work, and we're mindful of that, given our experience and our understanding of the kind of impact that COVID-19 has had on our entire population. And finally, rebuilding public health services. We are, that's the next slide, working on restarting or scaling up other public health functions as COVID-19 allows us and as our resources permit. And again, another interesting point for the board is that we are really taking advantage of the lessons and innovations that we were able to put in place over the course of the last couple of years so that we can improve service delivery, improve our reach, and actually really make the best use of the resources that we have, even as we know we have to have resources still directed towards COVID response and response to some of the other emerging infectious diseases that I've spoken to already. So some examples that are listed for your benefit here include things like virtual breastfeeding consultations and video-based assessment of suspected rabies cases. These are ways in which we can ensure that the service and the protection and the promotion service that we provide to the public is provided, but in a way that it is most, that makes the best use of the resources that we have to try to provide the benefit to as many people as we possibly can, given our current circumstances. Next slide. And I'm reaching the end of the presentation. I do promise this. I realize it's been quite a long one. This actually just speaks to the recommendation that is contained in the report before you today. We know that the pandemic has demonstrated that we can address and tackle very complex, very difficult population health issues when we are really focused on putting our time, putting our resources, and really engaged in the kind of collaboration that's necessary to tackle those complex and difficult issues. We have every intention of continuing these important collaborations and addressing these complex and difficult population health issues in order to make good on our obligation to the residents of this city, to help them achieve and maintain good health, to reduce inequities in that health status, and to ensure that we are able to respond effectively, that we're prepared for as best as we can be, and that we're able to respond effectively to outbreaks and public health emergencies. We know that we must not just look at the short term, which is really what this report focuses on right now, but that we need to think about a longer term approach. And that will require the collection of data and a process, I think, ultimately to establish a longer term strategic plan. So with that in mind, you have in the report in front of you a recommendation asking us to report back to you early in the new year with an update on, new, resumed, and enhanced public health functions, as well as a process for the development of a new strategic plan to guide Toronto Public Health's long-term priorities, keeping in mind what is the state of health in the city of Toronto at that time, and what do we need to focus our efforts on in order to make good on those goals and objectives. Again, improving the health status of the population, reducing inequities, preparing for and responding effectively to outbreaks and public health emergencies, all with a mind to using evidence, to focusing on equity, and as well in recognizing that public health is truly a public good. So last slide is the next one. As I have done for all my presentations to date, I do want to issue my thanks, as always, to many, many people. I first thank the members of the Board of Health, including those of you who are just assuming seats at the Board of Health, recently. I do want to thank all of the staff at Toronto Public Health. All the progress that we've made to date is due to this remarkable team at Toronto Public Health, and as well the efforts of our partners. We have many, many partners within and outside of the city to whom I am eternally grateful. I would like to take a moment as well to just say that, look, it has been a very, very challenging time. And in fact, as I looked it up, as I have done for many other Board of Health meetings, today marks day 877 since COVID was first identified in the city. So it has been, certainly at least 877 days of pretty heavy lifting for the team at Toronto Public Health, to say nothing of the many partners who also were significant contributors to the response. I do think it is important that we give the team some opportunity over the course of the summer, which is just about to start tomorrow, to rest and recover in order that we can continue to provide the amazing service that has been provided over the last couple of years into the future. We do want to foster a resilient workforce and enhance supports for our staff as they work to address those priorities that are outlined in the report and that I've outlined for you in today's presentation. But I do think that first and foremost, a period, an opportunity to rest and recover is an absolute priority that I have for the entire team at Toronto Public Health. I do want to just take a moment because this is, one of those meetings. So if the board will just indulge me for another few minutes. I do want to thank all those who've been instrumental in preparing this report and the other reports that were before you today. A special shout out to my colleague Dominic, who remains the picture of professionalism and calm despite too many plates that he has to keep spinning on too many sticks. Dominic, thank you. You are a remarkable professional, and we are thrilled that you are part of our team. There are many, many others to thank, but I would like to make note now just of one final group. Right, 877 days since COVID was first identified here in Toronto. I still am, flabbergasted to think about that. But it's with that in mind that I would like to offer special thanks to the senior leadership at Toronto Public Health. This remarkable group of individuals and professionals, they and their families have made remarkable sacrifices to respond for the last 877 days. And while there may never be enough ways to say thank you, I can at least try. So, Gail, Michael, Althea, Megan, Nakoshi, Howard, Nicole. And I would be remiss if I didn't mention Melvin, who, lucky for him, moved on to retirement last year, and our latest addition to our team, Upala. To this remarkable senior leadership team, again, I don't know that there are enough ways to say thank you, but I will start off by offering you this note of thanks for all you've done and for the many sacrifices you've made. So with that, Mr. Chair, that wraps up my report, and I will now hand the microphone back over to you.
Thank you very much, Dr. Davila. And of course, the board adds its vote of thanks to all the people that you mentioned. We do have one deputation on this matter before we go to questions from the board. We have Derek Moran. Derek, it feels like I just welcomed you yesterday.
I told you, huh?
Over to you. You've got 5 minutes. You know the rules.
I wanted to follow up on what candidate for mayor Chris Langenfeld spoke about here last month, where he was about reporting from Diverge Media, which has documented that Dr. Davila's husband has received money from COVID vaccine makers, and how it's kind of outrageous that not only has she not disclosed that conflict of interest, but nobody in the mainstream media has talked about this, and this board so far to date has not questioned her about this. So this is from Faskin, Campbell, Godfrey versus 7-Up Canada, where the Ontario Court of Appeal said in 2000, this line of authority requires a fiduciary to account to beneficiaries for any gains resulting from the fiduciary's position, even where the fiduciary acted in good faith and in the best interests of beneficiaries of the trust. But I wanted to bring to the attention of the Board of Health today that I have very good reasons to believe that the Toronto Police Services Board may have drawn Dr. Davila by implication into a fraud that they are about to commit on the public in regards to fabricating a COVID public health guideline they allude to in a press release for their upcoming meeting on Wednesday. This is the email I sent to the contact on the press release, Sandy Murray, a Law Society member and part of the police board staff. Hi, Sandy. So in this press release with your name on it at the bottom, it says, the board's meeting will proceed as a hybrid meeting. This is consistent with recent changes by the City of Toronto in the way it is holding its City Council and committee meetings. In an effort to make our meetings as accessible as possible to the general public, our hybrid meeting model will have a limited number of in-person participants, including members of the public. Every effort will be made to ensure as many members of the public who wish to attend, given room capacity limits and public health guidance. While this is truly fascinating example of Orwellian doublespeak, I was just wondering, When exactly did Dr. Davila issue a public health guidance that said TPS meetings and only TPSB meetings should have room capacity limits? I just want to make sure the Toronto Police Services Board isn't lying, so help me God, and police officers take an oath that ends in the last sentence, so help me God. So this is from Curley versus Latrell, 1920, where the Supreme Court mentioned falsus in uno, falsus in omnis. It's a maxim of law that says false in one thing, false in everything. You're like, you lied to me once, so I can only expect that you're lying to me always. Is this? Oh, no, that's not working again. Okay, so I don't know if you've noticed, Councillor Mihevc, this tweet being circulated around on social media. This is from Peter Evans on June 24th, 2020. He writes to Toronto Public Health, I'd like to understand why you are instructing the media to record any death as a COVID death, even if the death was caused by unrelated conditions, reasons, according to doctors. Someone at Toronto Public Health responded, individuals who have died with COVID, but not as a result of COVID, are included in the case counts for COVID deaths in Toronto. So how exactly someone gets counted as having died of COVID, but not as a result of COVID, without that being fraud, by the way, is beyond me. But I do want to thank at Toronto Public Health whoever gave that response for their candor nonetheless. Now, I don't know, Councillor Mihevc, if you've ever wondered what the the infection fatality rate for COVID is. This is from, I made this presentation to the police board a few months ago. This is from one of those scientific literature article websites, NCBI. It's about a mask wearing article. But at the very bottom in the conclusions, it says in early October 2020, the WHO also publicly announced that projections show COVID to be fatal for approximately 0.14% of those who become ill, compared to 0.10% for endemic influenza. Again, a figure far lower than expected. And not only that, but unlike Dr. Davila, this article, the authors of this article actually provided the source. So anybody can actually go look it up and read it for themselves.
30 seconds left.
So it's pretty gobsmacking to think that the survival rate for endemic influenza is 99.9%. The survival rate for COVID is 99.86%, and that the WHO has known this since early October 2020. What's even more surprising is that Dr. Davila has never disclosed this data to the public.
Derek, as always, thank you very much for your presentation.
It's good seeing you at Mike.
Cheers. Okay, we'll take it there. Seeing no other deputations, we'll take it into the board, and this is our period to ask questions of Dr. Davila. Questions of Dr. Davila. I see Dr. Mulligan. Nice to meet you virtually. Go ahead.
Thank you, Mr. Chair. You too. I do have a few questions for you, Dr. Davila, and I wish you well in your bout with COVID. I've been through one at the same time, so I know how you're feeling right now. I have a few different questions. They're not really connected to one another. First of all, I wanted to ask about monkeypox. And what in the way of supports are being given to people who need to isolate if they've contracted monkeypox or they're a close contact or otherwise have been directed to isolate? Are there sick days available? Is there isolation, hotel space, that sort of thing?
So if I may, through the chair, I might ask one of my colleagues to speak further to this. Perhaps Dr. Finkelstein, you're a little closer to the file. But Dr. Mulligan, let's start off with this. You're quite right. There's quite a bit that goes into the case and contact management, and we have opportunities through case management to at least understand what the circumstances are. I know we're working with our provincial counterparts on ensuring that supports are as available as they can be, but perhaps I can turn it to my colleague as he may have more specific advice on this.
Thank you, Eileen. Yes, we are working with our provincial colleagues and colleagues in our community to investigate ways of supporting individuals who have to isolate. We've also reached out to ensure that we do have access to the potential places in our isolation center that we have used for COVID individuals as a potential location for people to isolate where we feel, where we hear that there are challenges. So we're working, as Dr. DeVille indicated, we're working with our partners on this. Thanks.
Thank you. My next question is about COVID in Toronto community housing buildings. Dr. DeVille, you mentioned that there are some buildings that have lots of seniors that are naturally recurring retirement communities. Some of them are Toronto community housing. Could you give an update as to what's happening with respect to ventilation and trying to ensure cleaner, safer air for people living in those buildings?
Well, I don't know that I can speak specifically to what Toronto community housing per se is doing, but we certainly know that that when it comes to this time of year, the opportunity, as I mentioned in the presentation, to take advantage of the nice weather, we have fresh air available to us. So moving things as much outdoors as is possible, and using windows and opening them and allowing for more circulation of air does make a difference. I would be very happy to follow up specifically with our Toronto community housing partners on what their specific plans are on the go forward basis. But let me just say this. I would say that overall, the question you raise is one that is out there in the broader scientific community and in the community of people who have responsibility over buildings and indoor environments where large numbers of people tend to congregate. So I think there's lots of lessons we've learned over the course of the pandemic. And my expectation is that those lessons will be and are actively being considered. And it may take a little bit of time as people are working their way through all the many things that we have learned over the course of the pandemic and how best to implement them in the various environments.
Okay, thank you. I look forward to hearing that update. My next question is about masking. You had a slide that said masking still required on wheel-trans and shelters, retirement homes, long-term care. What is the mechanism by which this requirement is in place? Is this a piece of city legislation?
So oftentimes it's actually through policies. So individual institutions and organizations are still at liberty to implement policies that for their particular settings. And of course, I think that when you hear what comments are being made, whether from the Chief Medical Officer of Health for the province or even at the federal level, the reality is that, things are better now, certainly improved. You've seen the data thus far in respect of COVID-19 activity, but I think we have to remain vigilant. And of course, part and parcel of that is making sure that we're observing the trends, that the global partnership that has occurred over the course of the last 2.5 years continues to be maintained and sustained so that we know what's happening. Because conditions, we've seen that this virus has thrown us a curveball on more than one occasion. And I think it just behooves us to be ready for that which may come in the future, recognizing that, protections may need to be reinstituted depending on what the future holds for us. But, for now, I think, using the policies that exist, using the levers that exist, and certainly taking advantage of the nice weather are going to see us through the next several weeks, at least for now.
Thank you, Mr. Chair. I have further questions, but I'll wait till the next round.
Okay, great. Thank you. Thank you very much for understanding that. Next is Councillor Fillion.
Thank you. And thank you, Dr. DeVille. So I just wanted to follow up on something you'd mentioned in your presentation that I think is a concern to all of us, but the postponement or putting off of screening for just, many illnesses or just annual checkups. Do we have any stats on the extent of that? I would think anecdotally it would be very large, but I just wondered if we had any fairly recent stats on the prevalence of that problem and the beginning of the evidence of the health outcomes from that problem.
So through the chair, Councillor, I do not have the statistics in front of me today. I know that our healthcare partners, there are agencies that oversee the data in respect of our healthcare system, and including our cancer screening system, just as an example. I'm certain that they have some data and they would probably be the best source. I would be very happy to bring that back or perhaps share that with members of the board if that's of interest. But I'm sorry, I don't have them in front of me at my fingertips at this point in time.
Sure, thank you. And I'm wondering, do we know whether family doctors are initiating starting things up again, like sending notes to patients saying, we noticed you haven't been in for a checkup in 3 years, we're doing checkups again? I haven't personally noticed that, and I'm kind of wondering why not.
So through the chair, my understanding, and again, this is largely through the connections I make through our primary care colleagues and providers, I think you have quite a bit of variation amongst primary care providers. There are some physicians that have been actively engaged in in-person care throughout the course of the pandemic, and others who are just starting up. So I think you see the range of activity across different primary care providers and practices. And I know that there are a lot of efforts underway to try to make sure that people are able to access primary care as much as possible. But again, that's within the realm of healthcare, where we hear from the side, if I can use that term, more so than have purview over that.
Yes, thank you. And one question just on the vaccination stats, that 70% 60 and over have had a third dose, but only 27% have had a fourth. So if you combine those two, it sounds like roughly half of those who had a third dose have decided, can't really be bothered, not important. Do we have any data to point at for those people to show them that it is important, that it, apart from the generalities about, 4 are better than 3, but as far as stats about severity of illness, either, hospitalizations, ICUs for that age group, from the difference between a fourth dose and a third dose?
So through the chair, Councillor, that's the kind of information that we're seeking to provide through a variety of different channels, certainly through our public communication streams, but as well through our community ambassadors and vaccine engagement teams to ensure that the relevant population is aware of the benefit of getting all the doses of vaccine for which they're eligible. I would just add this is a little bit more complicated given the infectivity of Omicron and just how much illness there has been. The current advice right now is that if you've just had a COVID, infection, that, you can reasonably, while you can get a vaccine, your next dose of vaccine safely, once you are no longer infectious and you've recovered from the symptoms of your COVID-19 infection, the advice is to wait, for a few months before, right, in general, from an individual level, to sort of maximize the benefit of the protective components of the vaccine. So, I do wonder about how much of it is just a question of people who've recovered from COVID infection or had recent COVID infection, and are delaying that vaccine until, a number of weeks have passed so as to maximize the individual protective benefit of that vaccine. But of course, we want everybody to get all the doses for which they're eligible, so that they can experience that protective benefit, and so can all the people around them.
Okay, thank you.
Thank you very much, Councillor Fillion. Any other questions? Councillor Robin Buxton-Potts.
Thank you very much, Chair. Dr. Davila, thank you so much for your presentation, and lovely to work with you in this capacity. I apologize. Joe, your mic still on in the committee room? Because I think we're getting some feedback.
Oh, could be me, sorry.
I think we fixed it. Thank you so much. I thank you very much for all of your work over the last 877 days. I remember that very first press conference with that first case and former Councillor Wong Tam. It feels like a lifetime ago. I did want to ask a couple of questions about the monkeypox vaccination rollout. I'm sure you saw that, especially on Friday, there were some concerns about the number of dosages and how that was being communicated to the more at-risk communities, especially during Pride Month. And I'm just wondering if you could speak a little bit about how we should be communicating to our residents about their eligibility and making sure that they are being targeted in a culturally a culturally appropriate way.
So through the chair, thank you for the question. Let me start off, and then I'll see if Dr. Finkelstein has anything he wishes to add. This is a new vaccine, one that we haven't used before, and frankly, I would hazard that most healthcare providers in our city have not used before. So we have taken a very careful approach to this. It's important that we're providing the vaccine, absolutely, and we want to do so in a responsible fashion. We have focused our efforts on those communities that are at greatest risk. And in particular, we have worked with key community partners to ensure that our messaging and our promotional efforts make sense. They're getting to the populations at greatest risk and do so in a way that's sensitive and respectful. I don't want to, necessarily say that it's all one particular group. I do think it's worth pointing out that the Gay Men's Sexual Health Alliance has been a key partner for us, amongst others, and they've been very, very supportive. We are offering vaccine now within our existing fixed clinic sites that we have throughout the city for COVID-19, but as well are focusing some of our efforts on venues where we know those populations who are at higher risk are known to frequent. So we have clinics that we're doing in partnership with healthcare providers as well who serve higher risk communities as well. So, whether it's at bathhouses, those clinics in partnership with healthcare providers who focus their service towards men who have sex with men, these are the kinds of things that we're doing to make sure that the vaccine is getting to those populations who are likely to benefit from it most, given the current epidemiology. Michael, I don't know if there's anything you want to add.
Thank you, Dr. Davila. I think I just wanted to take off from your last point is that we are using the epidemiology of what we're seeing with reported confirmed cases and how that is guiding us on both where the vaccine is being offered and also who we think is at increased risk and therefore is an important at-risk population to hear about the vaccine and access it. But I also have to really not forget our close working relationship with the Ministry of Health, who are providing the guidance and the eligibility criteria that we are using to going out into the community to promote the vaccine for a particular group of at-risk individuals. And so we do take our guidance from the Ministry of Health, who are looking across the cases and suspect and probable confirmed cases to understand who's at most at risk. And as Dr. Davila indicated, trying to get the vaccine into communities where we know there are at-risk populations, and really building a collaboration with that community to determine where that best is. Thanks.
Thank you very much. And just really quickly, I think what we saw over the weekend was a really great sort of proactive uptake in the community that we're talking about, who were then felt a little disappointed that there was only, I believe, 100 vaccines available at one clinic on Friday, and about 400 people turned up. So I'm wondering if we have a sense of when there might be more vaccines available for them.
Well, thank you for. I think it's always difficult, as Dr. DeVille indicated, when we're talking about a brand new vaccine, trying to balance the importance of bringing the vaccine to places where we can vaccinate a number of people, but also be cognizant of making sure that we have vaccine for future events. And I think Friday was one of our first days when we were putting in very much larger clinics. We had a number of smaller clinics to really pilot our use of this brand new vaccine. And Friday was the first day. And so I think you have highlighted the fact that trying to get that balance right between going to places where the community can access the vaccine and at the same time having the number of staff and trying to estimate the demand, sometimes that's going to be challenging. The next day, we had a number of much larger venues. We did quite a few vaccinations. And so we're working with the community to try to respond to their demands or needs for the vaccine. And that's why this week, we have a number of clinics that are going to be in places where the community is knows, and that hopefully will be able to offer the vaccine to more individuals.
So if I may just add, sorry, Councillor, if I can add through the chair, you know, of course, procurement and supply is under the purview of our federal and provincial counterparts. But Michael's quite right. We are building up our capacity to deliver the supply that's provided to us in keeping with the eligibility criteria. And I would just say this, we also want to make sure that while we're providing that protection to those who might benefit from it, at the same time, we want to make sure that there are supplies of vaccine available, given that we're not in control of that directly, for those circumstances where we need it to follow up, for example, on a known exposure. So yes, we want to have that protective benefit for those who are at risk in a more proactive way, but we also want to make sure that we are still able to provide that benefit for those who clearly have an exposure history. So it's a very interesting and delicate balance. And, you know, my hat's off to Dr. Finkelstein and the team that he is leading in this regard. They pulled together these clinics, you know, in really remarkably quick time and have done, you know, I think a really remarkable job of it. So thank you to Michael and the entire team.
Councillor Robin, we'll put you on a second round if you want, so just hold on. We'll go to other questioners. Any other questioners for round one? I have some around two questions around first round. I'll run the clock on myself. One is the vaccine for 5 and under, noting that in the United States that's now a publicly available vaccine. And I'm thinking of the parents who are wondering about childcare, entering kindergarten, junior kindergarten, senior kindergarten. Is there anything that we can tell them as to when that might happen and how it's going to roll out and what they should be thinking of over the summertime as they are preparing for the fall? That's my first question.
So very briefly, if I may, through you, Mr. Chair, as I mentioned in the presentation, yes, the products have been approved in the United States. You know, we are awaiting approval here in Canada. It is a separate process, as we've seen with the other vaccine products that have been made available over the course of the pandemic. As I mentioned in the presentation, we are actively working with parents to understand what makes the most sense for them. And I think we're also trying to establish, what kinds of information products would actually help them in terms of making their decisions to support the best health for their children. So these are the kinds of preparatory activities that we have ongoing right now to support the campaign. I don't know that I can give you an exact timeline. Some of my colleagues are probably a little bit closer to some of those discussions. I expect we're looking at something, in a couple of, right, towards the end of the summer, if you will. And again, this all rests on the review process that needs to happen at Health Canada. Certainly, we have heard at the outset that parents are interested in seeking this vaccine from their primary care provider, a much more established relationship, a more, I guess, an intimate environment for vaccine, probably more important, particularly when we're dealing with younger children. Certainly, we're trying to put information out there, and we're asking people, as we have throughout the entire campaign, to please speak with their healthcare provider around their concerns and their particular child. That's the best way to really understand a vaccination decision at an individual level in the context of a trusted relationship with a healthcare provider. As your local public health department, we can absolutely provide general information and advice. But, we have a number of primary care providers here at the table, one a pediatrician, the other a family physician. I think they will vouch for the fact that, the best advice that we can give around individual level decisions, especially around vaccination for young people, that should really happen in the context of a trusted relationship with a healthcare professional. As public health, we're happy to provide general information and general support, but the best individual level advice really has to happen within that context of that relationship.
Okay, my second question is, you did a very good job of not hinting, but articulating at a very high level the priorities for the short term. And, I note that in the health sector, not the public health sector, but the health sector, they've got a number of quantifiable stats that they have put out, how far behind they are in surgeries, what the backlog is in a variety of medical procedures and so on. Is any of this quantifiable? Like, what I'm thinking is there's a big backlog, a lot of work that we got to get back to, and even on the budget side, do you need more resources? Or will you be able to manage with the resources that you have? What are the implications of going one way versus another way in the area of public health? So, what areas, you've articulated the areas that have suffered most and that we need to focus on. What do we need to do? What do we need to get ready for, both for the City Hall, asks of City Hall, asks of the province? Maybe a few more comments there would be helpful.
Sure. So through you, Mr. Chair, a couple of things. You're quite right. When it comes to the healthcare sector, they are able to be extremely clear around, how many surgeries they are behind or how many assessments they are of a variety of different natures that they need to get through in order to get caught up. Unfortunately, we don't have the same luxury in public health. And I say that with a little bit of trepidation, as you can sense, I'm sure. But that's because we're not a program and service delivery agency quite like healthcare. We're a little bit different that way. So there are some of our services where perhaps a more quantitative approach can be adopted. We do have some clinical services. For example, we have dental and oral health services. That's probably easier to count, just to give you an example. But when we talk about the kind of work that public health does, and when our outcomes are actually measured over the course of 10, 20, and 30 years, right? Because we're in the business of prevention, it's a little more challenging for us to really start to articulate, what the impacts are in quite the same way that is done for healthcare. That being said, we know that there are certain areas of work that we're going to need to be far more active in. And I think that will require, new resources if we're taking these things over and above that which we were doing before. Certainly we are doing our very best to take full advantage of technology and other innovations that we have discovered over the course of the last 2.5 years out of necessity. So I don't know that I can provide you with an exact figure quite yet. That's part and parcel of why, at the senior leadership level at Toronto Public Health, we're interested in understanding what our current health status situation is in the city and ultimately developing that longer term strategic plan in consultation with you and in consultation with the people of Toronto and our other key stakeholders. I think that's where we're really going to be able to articulate what needs to be done on a go forward basis and what kind of resourcing that's going to require. So I'm sure that that's not the most satisfactory answer for you, Mr. Chair, but it is about as far as I can go at this point in time.
Thank you very much. Gives us a sense of the lay of the land. Any other questions? Round two, Dr. Mulligan, I think you wanted a round two. Go ahead.
Thank you, Chair Havoc. I have a couple more questions. One is, could you give an update, Dr. Davila, about advice to residents in the form of a health promotion campaign? It's something that the board requested at, I think, our last meeting or the one before. Your slide on advice with respect to the summer was excellent. Are we going to see a campaign around this to help support people make healthy decisions?
Through the chair, the answer briefly is yes. And as we move into fall season, right, that's summer, and as we move into the fall and we increasingly retreat into indoor environments, you can expect to see us actively communicating with a campaign on the shift that's going to be required at that point.
Fantastic. Thank you so much. Then a quick follow-up about the indoor air quality. I understand that Peterborough has piloted a project of loaning CO2 air monitors to people so that they can check on the air quality in their homes. Is this something that's been considered for here in Toronto? Is it something that TPH would consider exploring?
So through the chair, I think we explore all opportunities that are out there, and I would personally prefer to see something of that ilk happen in a more consistent and systematic fashion if in fact it's warranted and shown to be a benefit. I think there are some questions around the validity of this and whether it actually does substantively make a difference. That's why I'm more interested in seeing, say, for example, a provincial agency like Public Health Ontario undertake, an assessment and a determination as to whether in fact that kind of initiative makes sense, not just for, a single jurisdiction, but for jurisdictions all around the province. And it should be done with, the best available evidence and with some implementation plan that makes sense, assuming that it's supported by the evidence.
Thank you so much. My next question is around integrating mental health promotion into the work of Toronto Public Health going forward. I was really happy to hear some of the examples you gave about how this might go forward. It was 2 years ago now that the board asked TPH to look into social prescribing as an approach to this, which would be really, using the opportunities and encounters that TPH has with residents of Toronto to help refer them to supports and services for their social determinants of health and their mental health. Is this something that's being used in the integration of mental health promotion across TPH?
So through the chair briefly, yes, this is exactly the kind of thing that we're talking about. And perhaps we may not in our own minds conceptualize this as prescribing because most of us don't see ourselves as prescribers per se. I might have once a long time ago, but I recognize that many of my colleagues around the organization don't necessarily see themselves in the business of prescriptions. That being said, the kind of advice and referrals that we do provide are exactly, I think, what's captured within social prescribing. So as I mentioned, it may not be the way we conceptualize our activities, but it is indeed in line with that.
That's amazing. That's wonderful to hear. And I have one last question, Dr. DeVilla, and thank you for staying with me through all these. It's around the public health as a public good. And I was just hoping you could expand on that a little bit and update us on the status of provincial conversations around public health modernization. It was such a big issue pre-COVID. We've now had a provincial election. As we are moving into this kind of new political time, which is later in COVID and a new government or a renewed commitment in this government, what's the status of public health modernization and how does it relate to that work of public health as a public good?
So through the chair, excellent question. I don't know that I have a complete answer for you on where the provincial government is thinking right now or what their current approach or thought is in respect of public health modernization. You're quite right. It was something that they were actively pursuing in the months immediately preceding the identification of COVID-19 globally and the identification of COVID-19 here specifically in the city. The new government is, or the newly elected government is still forming, as I understand it. So we haven't really had the opportunity to have substantive conversation. But I would say this, my hope is that over the course of the last 2.5 years, there is an increasing understanding as to the benefit of public health as a public good, in that it is something that provides for everybody. It is to the benefit of all of our communities, including this very one here in Toronto. And with that in mind, the notion is that because we're working for the common good, to support everybody's ability to experience optimal health, part and parcel of that is to reduce inequities in health status. And the more we are able to experience good health in all strata of our society, frankly, the healthier we all are. This has been demonstrated time and time again. So certainly happy to have those conversations as our newly elected provincial government more formally, if I can use that term, takes its seats and starts to figure out what their agenda is on the go forward. And certainly we're eager to ensure that the benefits of a strong public health sector are made clear. It is, yes, absolutely about health. And as it turns out, given that the economy is so much on people's minds, you can't have a strong, healthy economy without strong, healthy people. That's just a given. And so to my mind, there is lots of opportunity to have very productive conversation around what we can do to support healthy people and a healthy economy.
Thanks so much, Dr. DeVilla.
Thank you.
Thank you very much, Dr. Mulligan and Dr. DeVilla. Last call for any questions? Further questions? Okay, to speak. Any speakers? Don't be shy. Okay, maybe I'll request, I don't know, Ashna to move the staff recommendation, which is very simple, that the Board of Health request the Medical Officer of Health to report back to the Board in 2003 with an update on the new resumed and enhanced public health functions, as well as a process for the development of a new strategic plan to guide Toronto Public Health's long-term priorities. You're good with that? Yep, let's see the nod. Any debate or discussion? Thank you, Dr. DeVille, for the report, for the preparation, all the good work on COVID, and for thinking ahead on what happens with other parts of public health. I love that term, the public good. There is such a thing. It's knowable, it's doable, and I think we're all trying our best to figure out what that is and how to contribute to it. I think this report begins that process. Okay, all in favor of the motion? Hands up. Thank you very much. Opposed, if any? That carries. Okay, we have one more, well, 1.5, two more items to go. Hang in there. Next is the Toronto Overdose Action Plan Status Report, item number 3. We have a staff presentation. Dr. Davila, I know you've spoken a lot, but here you go again.
So thank you, Mr. Chair. It is indeed me again, and so far my voice is holding out, so all good here. Thank you again to you, Mr. Chair, to members of the Board of Health. I will be providing you an overview of the Toronto Overdose Action Plan Status Report 2022. That report is before you today, and I know that you all have that report in and amongst the materials you've received. For those of you, if you cast your mind back, this annual report is something that we routinely do as part of our accountability on the implementation of the Toronto Overdose Action Plan. And by way of reminder, that plan was initially endorsed by the board back in March of 2017 and updated in June of 2019. Last reports, though, regarding this issue were brought to the Board of Health last year, once in June and again in December of 2021. So just to give you a sense as to what's covered in this report, it does highlight a number of the key actions that have been taken since last year. And as you will have seen in the report, it makes some recommendations for further action. So let's go right into the slides, and I will ask Bree, who is driving the slides for me, to advance. Thank you very much. You know, I think this chart speaks for itself. We know that since 2015 in particular, there have been a high number of drug poisoning deaths in Toronto. If you look towards the right-hand side of the slide, these are data, a summary of data from the Chief Coroner's Office. This is the Chief Coroner for the province of Ontario. The preliminary data from the Office of the Chief Coroner for the province indicates that an estimated 511 confirmed opioid toxicity deaths occurred in 2021. Again, these are startling numbers and continue to really create much concern and give rise to much concern, as it should for all of us here. You can see in the purple line as well that there are data in respect of suspect drug-related deaths. That's at a much higher figure, estimated for 2021, based on Chief Coroner data at 874. It's important to pay attention to this as well. These data on suspect drug-related deaths are not specific to opioids, and these data are used to help track early signals of potential trends while we await more complete data on drug-related deaths. So what we're seeing here is that clearly we have record numbers of drug-related deaths in Toronto in the last year. That 511 confirmed opioid toxicity deaths is a 273% increase relative to what we saw back in 2015. Unfortunately, these numbers are not moving in the right direction. Next slide. We can see that this is also echoed in the data that we have on fatal overdoses attended by paramedics, and that we have seen an exacerbation of this since COVID-19. And on this graph, you can see the number of monthly fatal suspected opioid overdose calls attended by our colleagues at Toronto Paramedic Services. This goes back to August 2017. This is when we first started monitoring those data. And you can see that they've increased overall, a general higher trend after the declaration of the COVID-19 emergency in March of 2020. So, and just to give you a sense as to the increase that has been noted over time, looking at the data that we have in front of us from August 2017 to March 2020, our paramedic services colleagues attended an average of 13 fatal calls per month. And after March 2020, that number doubled to 27 fatal calls per month. And looking at the most current data from January 2022 to April 2022, the average number of fatal calls has been about 24 per month. So clearly we are seeing some significant challenges in respect of fatal overdoses and calls made to paramedics in this regard. Next slide. So you can see in the data that there has been a dramatic increase in the number of drug-related deaths in Toronto since the COVID-19 pandemic began, and that this situation does continue to worsen. We know that deaths involving all substances in Toronto have increased to record highs, unfortunately. We are seeing an increase in deaths caused by both opioids and stimulants. And truly, what we are seeing on the ground goes beyond an opioid poisoning crisis, and I think is more accurately described as a drug poisoning crisis overall. Next slide. Unfortunately, as you know, this is having really dramatic impacts on people who use drugs in our community, and they face a number of significant challenges. We have an unregulated drug supply that is increasingly contaminated with unexpected drugs and toxic substances. And, you know, as you've heard through previous reports, there's been an ongoing need to expand harm reduction and treatment services for people who use drugs. But I would say this, that unfortunately, COVID-19 has intensified this need because services have had to adapt to slow the spread of COVID-19. And unfortunately, this has created some limitations in respect of the hours that services are able to be offered, and in other cases has reduced the capacity that each of these services can provide. We also know that the ongoing criminalization of drug use and people who use drugs continues to force people into unsafe behaviors, behaviors that actually put them at greater risk. And there is no question, there have been a number of actions taken to respond to the crisis. We're going to go over some of those a little bit in this report. They're articulated in the report. There are some that we're going to be discussing here in the presentation. But there's no question in my mind that more action is needed from all levels of government. We do need to continue to make sure that we're providing as much as possible comprehensive, high quality public health supports. You know, knowing that this continues to be a very significant situation that we're seeing on the ground. And we can anticipate that, you know, unfortunately, COVID-19 is not over yet. And we have certainly received some signals that we should be anticipating, and we have reason to believe that, you know, we have a challenging viral respiratory season ahead of us. So again, all the more reason to continue to take those evidence-informed actions that will make a difference, and to continue to strengthen the partnerships and collaborations that actually allow for these actions to take place. So just to give you a sense, next slide, of the kinds of actions that have been taken, or that have been, actions that have been taken since the last report to the Board of Health. This gives you just a high-level summary of the kinds of things that we've done. This is by no means a complete or exhaustive list, but just some highlights for the benefit of the board in terms of the work that's being done in key areas. So along with our partners, we are continuing to provide a drug checking service and an associated community alert service to alert people who use drugs and people who serve them around, you know, what toxic drug contaminants are being found in the unregulated supply, what poisoning events are coming to our attention. And in fact, since launching in October of 2019, we know that the drug checking service has been accessed over 6,000 times. Of course, supervised consumption services figure prominently in respect of our service offering. And with our partner organizations, we opened 6 new supervised consumption services across Toronto, 3 as urgent public health need sites, located at 3 hotel shelters. There is 1 at a COVID-19 isolation and recovery hotel for those who are experiencing homelessness, and 2 more such programs and services at base shelter locations. So this allows for residents in these different sites to be able to consume drugs under trained supervision to reduce the risk of fatal overdose. Again, an important part of the service offering that we provide in partnership with many other providers who are part and parcel of the network. Safer supply initiatives have been extended and scaled up. There are 3 such initiatives or safer supply programs in the city, including the one that we offer at Toronto Public Health, which is an injectable opioid agonist treatment program. We know our colleagues out at Parkdale Queen West Community Health Center as well offers a service. We have colleagues to the east at South Riverdale as well. I think these are important services that are clearly providing benefit. And I can comment on the fact that the program specifically at Parkdale Queen West has served just under 140 clients since it first started in 2020 and has a retention rate of almost 80%. It's in the range of about 76% based on my notes here. So we are seeing some initial success through these programs and are continuing to evaluate them. Hopeful that we're able to have more significant impact on people's lives as we get the results and monitor the evaluations and hopefully expand these efforts premised on the results of our evaluations. We know as well that there are Toronto Community Crisis Service pilots. This was just launched earlier this year, part and parcel of SAFE-TO, Toronto's 10-year community safety and well-being plan. This is a community-based approach to respond to mental health crisis calls and wellness checks with 4 pilots operating around the city with community partners. And this allows for better response, improved response approaches for people who use drugs and who are finding themselves in crisis. So again, very hopeful for this newly launched program. And finally, I'll just comment on harm reduction training for Indigenous peoples. This is an initiative that's actually being undertaken by our colleagues at Toronto Employment and Social Services. They've partnered in particular with two-spirited people of the First Nations to design and deliver an Indigenous harm reduction pilot. So what this does is it prepares Indigenous identified Ontario Works clients for opportunities to work in harm reduction and peer navigator positions. And my understanding is that as of March of this year, 15 graduates have successfully completed the program. Again, this is a very high level summary of some of the activities that are ongoing, but just something we thought was worth you hearing about so that you have a sense as to what kinds of initiatives are actually happening. Next slide. Just a little bit more by way of the kinds of initiatives and activities that are being done in collaboration with key partners on this file. Through the Toronto Urban Health Fund, we have provided funding for 19 harm reduction projects, including those that are Indigenous-led and provide a range of harm reduction services and programs, overdose response training, naloxone distribution, just to name a few. We are in partnership, Toronto Public Health and others, with the Toronto Academic Health Science Network hospitals to form the Toronto Opioid Overdose Action Network. This has a number of different partners. It's Toronto Public Health, those Academic Health Science Network hospitals, community health centers, and community service providers, really working together towards trying to provide seamless pathways of care for people who use drugs. We know that there are resources out there, but it's often in the connections and the transitions that unfortunately things have not always worked as well as we would hope. So this kind of network initiative actually allows for better collaborations, better transitions, and ideally better care and outcomes for people who use drugs. A wide range of services involved as part of this network, everything from rapid access addictions, medicines clinics, harm reduction teams, acute care-based addictions consultation services, just a range of different services, including services in the community that are meant to create better pathways and better experiences and outcomes for those who use drugs in our community. The Toronto Substance Use Crisis Centre is a proposal that's been shared with the provincial government to establish a 24-hour substance use crisis centre in Toronto. We are hopeful that this is something that will see some funding from our provincial counterparts and know that it would have a really significant impact and a real benefit to people who are using substances in our community, and particularly those who are experiencing crisis. We have the Integrated Prevention and Harm Reduction Initiative. This is a multi-pronged effort by the city and variety of community agencies to help enhance harm reduction and other prevention services to respond to the drug poisoning crisis within the shelter system. Again, really important supports that are required for this particular population, managed through this initiative. And this is an important collaboration that we'd like to continue to engage in with our partners. And then finally, I just wanted to speak to some of the work that's been done at Toronto Community Housing. They've developed a harm reduction policy thanks to leadership of Councillor Perks. And again, something to help support people in TCHC. If you'll excuse me for and we'll move on to the next slide. As directed by the Board of Health, thinking about the broader system and what kind of change is needed to support better health outcomes for people who use drugs in our community and for our community writ large. As directed by the Board of Health back in December of 2021, we did submit an initial exemption to Health Canada on the 4th of January of this year to decriminalize the possession of drugs for personal use in Toronto. So that exemption request, as I mentioned, was submitted, and we have since continued our work in this regard through community engagement and continued collaboration with some key stakeholders. Just to remind the board, if our exemption request is approved by Health Canada, it would apply citywide and to all drugs, and it would eliminate fines or other penalties associated with the personal use of drugs in the city of Toronto. We also believe that it would support better access and timely access to voluntary services and really just provide for a better set of circumstances for those who use drugs in our community. Of course, there isn't a single solution that will address all the needs as they exist. Decriminalization is just one component of what is needed. We've spoken a little bit about the need for health and social services to actually exist that are timely and accessible to those who need them when they need them. And on top of it, it's not just about the services that are needed, whether they're health and social services, but also the connections, the pathways, and the experience of people as they try to avail themselves of these services. These need to be better coordinated, more cohesive, and actually mindful of the fact that transitions are challenging times, so all the supports need to be in place. So I just wanted to provide you with a very high-level update. There are details articulated in the report around our request to Health Canada and the kinds of work that we are still doing. We're regularly engaging with our partners at Health Canada, but as well, really working through the details of what decriminalization might look like here in Toronto. And we're doing this in partnership, yes, with people who use drugs, and of course with the service providers who seek to ensure that we're doing everything we can to optimize the health of people who use drugs in our community. I think the other component that's worth talking about here is that you will likely have heard that there has been an agreement reached between Health Canada and the province of British Columbia on an exemption to the Controlled Drugs and Substances Act for personal use of small amounts of specific drugs. We know that this is a good step forward for our colleagues out in British Columbia. They had submitted their application for this to Health Canada earlier than we had, so we were not especially surprised to hear that they are a little ahead of us. Their circumstances, of course, are not the same as that which we're experiencing here in Toronto. So we still see that having our ongoing collaboration with our local partners and our ongoing collaboration with Health Canada as well is an important part of our process here in order to ensure that we're coming up with a solution and a proposal that makes sense for our unique circumstances. Again, we are not the same, the concept may be the same, but just as it is in clinical medicine, there is a general sort of treatment approach, but how it actually manifests itself will vary somewhat from patient to patient. That's no different when we're talking about something here at a population level. The differences are there, and therefore the solutions, while they may follow the same principles, should actually take into consideration the unique characteristics of our community and the needs of people who use drugs here. Finally, I just wanted to provide the board with knowledge that the team here at Toronto Public Health is in the process of updating the Toronto drug strategy. This strategy was initially developed by Toronto Public Health staff in 2005. And we've made significant progress, no question, on many aspects of that strategy, many of the action items articulated in the strategy, thinking about prevention, harm reduction, treatment. We now have supervised consumption services. You've heard about our forays into safer supply. We have partnerships that didn't exist before that are actually providing benefits to people who use drugs within our community. So more to do. And we would like to, at this point, update that strategy. It is, in need of an update since things have changed over time, right? The policy landscape has changed substantially since 2005. We do feel that now is an appropriate time to update the framework. And I think we have to take into consideration how much has changed since 2005. For example, over and above the different services that we now have available in concert with what was articulated in the strategy, we now have an environment, we now live in an environment where cannabis is legalized. The current realities of the drug poisoning crisis, as I tried to show you through some of the earlier slides of this presentation, our circumstances have changed significantly since 2005. And so now seems like an appropriate moment in time to update that strategy. And so, what we're doing is proposing that we take on this next bucket of work, if you will. And we are certainly interested in hearing from the community as we seek this refresh to the citywide drug strategy at this moment in time. So on to the final slides of the presentation. Sorry, Chair.
Okay, yeah, I'm just conscious of time, Dr. Davila.
Okay, I'm going to move us through very quickly. These last slides effectively articulate the recommendations that are contained in the report in front of you today. These are recommendations, many of which, if in fact not, I think maybe even all of them, particularly those directed towards the federal government and our provincial partners, have all been stated by this board in the past. So these are the recommendations in respect of that which we're putting in front of you around what's required at the level of the federal government. Again, reiterations of asks that the board has made of our federal government partners in the past. On the next slide, asks of our provincial counterparts to scale up prevention and harm reduction, to support more safer supply options, to provide for more sustainable funding for drug checking, and to fund the Substance Use Crisis Center. And again, these are articulated in the report in greater detail, so I won't belabor them here. And the final set of recommendations is for the board, that's the last slide, to ask of us at Toronto Public Health to continue our work with Health Canada on decriminalization, and to conduct community consultations throughout the rest of this year to inform a refreshed Toronto drug strategy. So with that, I will wrap up the presentation and just thank the board for their attention and just remind everybody that fundamentally at the end of the day, we are completely committed as Toronto Public Health to working with you, to working with our community and our other partners to really improve our collective response to the drug poisoning crisis. You know, I know we have seen what we can do when we put our efforts together, even in the face of some really very challenging circumstances. And I know that with the same kind of effort and vigor, we can, you know, make significant improvements towards the health of people who use drugs in our community and for our entire community as a whole. So with that, Mr. Chair, thank you for your patience, and I will turn it back to you.
Thank you very much, Dr. Davila. We have two deputants on this matter before we take it into the board. We have Susan Davis from the Gernstein Crisis Center and Alejandro Gonzalez Rendon. Are either of them here today or online?
This is the host.
Yes. I don't know if you can hear me. It's Susan Davis.
Oh, great. Thank you, Susan. Yes, you're online and we can hear you. Everything is good at our end. So please go ahead. You have 5 minutes. Thank you.
Thank you so much, and thanks for your time today. I'm Susan Davis, and I'm the Executive Director at Gernstein Crisis Center here in Toronto. Gernstein Crisis Center provides 24-hour crisis services across the City of Toronto, including a specialized concurrent substance use crisis team. Our work is rooted in community-based harm reduction, non-coercive approaches that are grounded by the involvement and leadership of people with lived experience. We are also one of the new anchor partners for the Downtown East Toronto Community Crisis Service, which is now linked with 911 and 211, hopefully providing greater access to supports for individuals who are experiencing a crisis and living with mental health and substance needs. Today, I really wanted to highlight some of the work that we've been doing in the Downtown East Toronto, Ontario Health Team. We've been working with diverse community and institutional partners to finalize a model, build a business case, and submit a proposal to Ontario Health for funding for a purpose-built substance use crisis center in Toronto, as Dr. Davila mentioned. The need for a crisis response for people who use substances has been long-standing. It continues to grow and has been exacerbated by the opioid drug poisoning crisis and COVID-19 pandemic. There is clear consensus of need from community members to emergency departments and emergency services. People who use drugs are not getting the support they need. They experience over-policing and incarceration, and with the current opioid crisis, unprecedented loss of life. The creation of a community-based substance use crisis center supports harm reduction and decriminalization by offering options to people who use drugs that are coordinated and accessible, supportive, connects them to needed health and social services, and are neither coercive or carceral. In 2021, the Downtown East Toronto, Ontario Health Team convened a group to move forward on this important and long-identified need in our community. The working group was formed with stakeholders from across the system, including South Riverdale Community Health Centre, the Neighbourhood Group, Street Health, Sherbourne Community Health Centre, St. Michael's Hospital, Gernstein Crisis Centre, the Toronto Drug Strategy Secretariat, and the City of Toronto, as well as community members with lived experience of substance use. This group built and expanded on previous work to develop a substance use crisis center in Toronto. The working group has also conducted consultations with various addiction medicine doctors and frontline workers to understand the scope of the problem and gaps that can be addressed through the establishment of this center. This community-led model will serve adults 16 and over and will include 24/7 safe space offering respite and stabilization, crisis intervention and follow-up, short-term crisis beds, peer supports and linkages to addiction medicine, safe supply, treatment, mental health and primary care, harm reduction services, and for those who choose long-term treatment. This collaborative model will incorporate and build on the current Gernstein Crisis Center substance use team and will function as an immediate crisis response, including telephone-based intervention, mobile visits in the community, short-term crisis beds, and up to 90 days of crisis management and follow-up. and will work with emergency medical services and the withdrawal management system to create a seamless and flexible flow between services based on the current needs of the individual in crisis. The center's design includes a model that allows for a response to a broad range of crises, as defined by the individual. This may include addressing an individual's mental health needs, physical distress, assessing for immediate safety, reducing harm, and promoting timely connection to health and social services. The overarching goal of the model is to provide a timely, trauma-informed harm reduction and appropriate response to individuals in crisis related to substance use and associated mental health issues. It would also reduce strain on first responders and emergency departments, improve service user experience, include a mental health response, connect service users to needed health and social services, and contribute to positive outcomes for the individual and the community. And while we recognize that this initiative crosses over all levels of government and ministries, the business case was submitted to Ontario Health for consideration in May, and we want to thank the Board of Health for their past support and are asking that the Board of Health continue to support us in this work and promote funding for the establishment of the Substance Use Crisis Centre here in Toronto. Thank you. Anybody there?
Yeah, thank you. Yeah, we're here. Thank you very much. Are there any questions of the deputant? Okay, thank you very much. Susan, we appreciate the good work that your intervention and the good work that the Gurdenstein Crisis Center does. Okay, our second deputant is Alejandro Gonzalez Rendon. Hope I said that correctly.
Apparently they're not on the line.
They're not on the line? Okay, then that closes the deputants. We'll now take it into the board. Are there any questions of Dr. Davila? Sue Wong, nice to see you. Go ahead, you have 5 minutes.
Thank you very much, Mr. Chair. Through you to Dr. Davila. I got a couple of questions related to the report. I hear a lot of echoing. Is it my end or is it something else? So I have a couple of questions through you, Mr. Chair, to Dr. Davila. On page 7 of the report, it talks about the Toronto Drug Checking Services is coming to an end on December 31st, 2022. And my question is, what's going to happen after December this year? That's the first question. Second, I noticed that in the report, it also asked for expansion and extension of the funding to the City of Toronto for this particular drug checking services. I guess I assume it's going to be through the Health Canada. Yet in the recommendation from Dr. Davila's report, it doesn't indicate asking for the Medical Officer of Health to ask for Health Canada to expand this program and ask for further, probably sustainable funding for this program. And then the third question I have is the new supervised consumption services. I noticed in the report, most of the locations are in the traditional downtown Toronto. Is there any plan to expand the program to make sure the cities northeast in Scarborough as well as northwest end to be included in this new supervised consumption services? And my final question to you, Mr. Chair, to the Medical Officer of Health is, again, I'm concerned about the safe supply programs. That funding will be ending March 2023. What are the plans by the city and the staff when this project will come to an end for funding next year? So those are my questions, Mr. Chair, through you to the Medical Officer of Health. Thank you.
So thank you for those questions. Let me start off with a few things, and then I will perhaps turn over to Sonia Bourgeois, who's our acting director and is more directly engaged on many of the issues on this file. So through you, Mr. Chair, there are a number of programs, you're quite right, Director Wong, that are funded as part of initial sort of grants that are provided. And unfortunately, when it comes to grants, the funding does end. Hence, you'll see there are recommendations that we've put forward for the board's consideration, asking the relevant parties to think about providing longer term, more sustainable funding for some of these initiatives, recognizing that they are part and parcel of a more comprehensive response. So I'll start off with that. There are also a number of our supervised consumption services, particularly those that are serving people who are in need of shelter and are part of the shelter service system, that are not located necessarily in the downtown core, that are located elsewhere. And we have partnerships with other agencies throughout the city for the delivery of harm reduction services and supplies. Those are not unique to just the downtown core. There are a number of agencies with whom we partner on harm reduction and services and supplies that are located throughout the city. But you're quite right. There's a lot of need. Hence, we're bringing forward these kinds of reports to you, making requests and working with our healthcare partners to make sure that we're providing as comprehensive a system of supports as we can, while we at the same time are working on the policy environment. But with that, I'm going to turn it over to Sonia and see if she has some specific answers for some of the other questions that you asked.
Thank you, Dr. Davila. And through the chair, maybe I'll first address your question around the Toronto Drug Checking Program. So first of all, that program is funded through federal funding, as you rightly pointed out, through the Substance Use and Addictions Program. Because it is time limited, as Dr. Davila said, usually those programs are funded for up to 5 years, and they do have a legislative cap for the federal government in terms of being able to extend them. However, for the drug checking program, we have had regular conversations with those specific stakeholders, and they're doing lots of outreach to the provincial government and to other funding bodies. So, for example, Ontario Health, as well as the Centre for Excellence in Mental Health. And there could be some potential working with the federal government to slightly change the program in order to be eligible for that time-limited project funding. So that's on the drug checking program. And then with your question on the supervised consumption services and expansion, we do agree there is a need to continue to expand those services beyond the downtown. And we've been hearing that a lot through our consultations on specific to the decriminalization work that we're doing. And so further to what Dr. Davila said, certainly expansion and ongoing work with our colleagues at Shelter Support and Housing Administration within the shelter system. But I will say that our Toronto Public Health staff through the works are constantly sort of getting requests from community agencies who are interested in establishing supervised consumption sites. And we do provide that type of support. So it's not necessarily led by Toronto Public Health, but we do play a very supportive role. And then finally, through Safer Supply, I think Dr. Davila has captured this. The funding is expected to end in March 2023. And that is similarly to the drug checking program. It is time-limited funding through the federal government, through, again, the Substance Use and Addictions Program. But there is possibility of potentially extending that funding. Of course, it would be at the purview of the federal government. And then in Dr. Davila's presentation, she spoke a bit about the Toronto Opioid Overdose Action Network, the partnership with our acute care partners and community health centers. And so through that, we anticipate that we'll be pulling together some additional funding proposals for consideration with Ontario Health and the provincial government. So certainly more to come, and we're quite active in this area.
Thank you very much. Thank you.
Thank you. Other questions? Seeing none from other board folks, I just have one, and it has to do with maybe it's what I'm seeing in the media, and of course it's influenced by the recent decision of the federal government to partner with the City of Vancouver and British Columbia around decriminalization. And I note that you do have recommendations here on that. What I'm wondering about is, this report is very comprehensive. Lots of recommendations going in oh boy, at least 7 or 8 directions. I'm wondering, what is that one thing, if the problem is a poisoned drug supply, is not the solution to be focused and pincer-like in addressing that issue. In other words, working on safe supply. And I understand that the federal government has some money on the table that might be available to really focus and expand that particular service. Recognizing decriminalization, yes, we need to work on that. And it's not a but, and in many respects, the Toronto Police are de facto practicing that right now. So is not the pincer that single thing that we really need to do quickly, rapidly, scale up is around safe supply?
So through you, Mr. Chair, I don't know that I could actively or really with any confidence say that there is one single thing that's going to make the biggest difference. I think there are lots of things that are absolutely necessary, of which safer supply and expansion of options and constant assessment of safer supply and its benefit, along with all the other elements, are what's required. Just as with many other things, this is a multifactorial, multidimensional challenge that's before us because it has to do with people's health. So there isn't a simple or singular answer. It's all of the above. And, you know, yes, we need an environment that actually supports, you know, people to adopt the right behaviors, healthy behaviors, behaviors that actually are protective of their own health. And we need viable pathways, healthcare pathways for people to successfully navigate, and methods by which to ensure that that even if the navigation isn't perfect, that there's a way to get back on to that pathway, even if there are deviations and you know, stumbles along the way. I think we know that it has to do not just about health, though. It's got all these other social elements to it. Housing, with all the necessary supports, opportunities to actually engage with the labor market, with employment, opportunities to re-engage and reconnect with family and other important social supports. It's all of the above. And so you will note, just to your question, Mr. Chair, in respect of safer supply options, there are at least 2 recommendations that are specific to safer supply in my read of the report that's in front of you. And so it does figure prominently, but I don't know that I would feel comfortable saying that it's the one, because I think it's the sum total of all the different supports together that really makes the difference.
Okay, thank you very much, Dr. Davila. Are there any other questions? Councillor Robin Puxton-Potts.
Thank you. Through the chair to you, Dr. Davila. You did mention that you weren't surprised that BC got their exemption before us. Do you have a sense from conversations with the federal government when we might get a response to that application?
So through the chair, I don't have a specific sense. The reason why I said that I was not surprised about BC getting their exemption in front of us was simply because they put in their application well ahead of us. They had actually put in their application in 2021. The City of Vancouver submitted an application in May of 2021, the province of BC in October, if I remember correctly. So clearly they have a time advantage on us. I can tell you that we're having very positive conversations with Health Canada, but I don't know that I have a sense as to time. And I will, of course, keep the board apprised of the conversations. We're quite pleased and having very productive conversation, I would say, with our Health Canada partners. And I'll look forward to continuing to keep you updated on how those conversations proceed.
Thank you very much, Councillor. Any other questions? Going, gone. Okay, so to speak, anybody want to speak and perhaps also move the motion? Councillor Robin?
Thank you, Councillor Joe. Just chair to the committee. I just really want to take this opportunity, and I hope you'll indulge me, even though I'm new, that this is a topic that is very close to my heart. In the interest of breaking my own anonymity, I am a recovering addict and alcoholic and drug user, and it's really only by luck and my privilege that I'm not one of the statistics that we're talking about. I have lost many people that I care about to the drug poisoning epidemic, and people that I love very deeply who work with drug users. The last couple of years has been incredibly challenging for them, and they have lost too many people. And this crisis is so acute and it's so important. And I'm just so grateful to all of the members of this committee for your work pushing this forward. It's so critical. And I think, Dr. Davila, you said it earlier, when we really put our mind and focus our resources to a problem, we can make a huge difference. And we're just seeing this problem get worse. And I'm just so desperate for the same kind of focus to save people. We know that drug users, some of them have addiction crisis. Some people, they are poisoned and die on their first time using. Lots of people use it recreational. They all deserve safety and care and love. So those are my comments. I'm so grateful, and I'm not sure that there's going to be another opportunity where a member of this committee can sort of come forward and identify with the communities that we're talking about and just say, with support and with care, there is recovery, there is life, there's joy. And I'm so grateful for the opportunity to be here and to keep pushing this agenda forward. Thank you so much.
Thank you, Councillor. I think I speak for the board in appreciating your openness in sharing that part of your story. Are there any other speakers to it? Okay, so I think Councillor Buxton Potts, you're moving the motion, a recommendation by staff. Last call. Okay, we'll vote. All in favor of staff recommendations as presented? Opposed, if any? That's carried. Okay. We have one more item, and it's from Councillor Buxton Potts. And that is the item of that staff will put on the screen. It is around requesting the Medical Officer of Health in consultation with City Manager to report back on a recommendation related to mental health to the next meeting of the Board of Health, which will be in the new year. That's the next regularly scheduled meeting. So I think just so that we're clear that we're not calling a special meeting for that, but it will be early in the next year. And staff have indicated to me that that's a doable task for them. But they cannot do it, say, for July or August or September, that would be impossible. So understanding that, any discussion on that? Okay, all in favor, take it down. All in favor, raise your hand. Any opposed? That's carried. That brings our meeting to a close, but let me say this, having just said that the next scheduled meeting is in early 2023 with the new council. In conversation with the Medical Officer of Health and senior public health staff, we will be monitoring especially developments in COVID and COVID response. We do want to give staff, for their mental health, for all the good reasons, overwork and so on, as much of the summer off as possible, but we will certainly be looking at it. We'll be in regular touch, Trustee Donaldson and myself with Dr. Davila. And if there is an emergency meeting that needs to be called in the summer, of course we're going to call one, but we're probably looking at, all things being equal, and they often aren't, at having a meeting in September, maybe another one in October, maybe two in the fall period. What is beneficial is, frankly, I'm not running, so I don't need to be hitting the bricks during that period of time. and we have enough citizen members to be able to perhaps, and Councillor Fillion also will not be running, so we'll be able to have a quorum, and also Councillor Buxton Potts also is not running, so there'll be enough folks there that we can have a quorum in September, October, maybe early November as well, if there is a need for some reporting back. So we probably will have a meeting, but we'll look to schedule it in early September. So you'll hear from us over the next little while. So with that, we'll adjourn the meeting, and I'll say thank you to everyone for attending and for your participation. This meeting is now adjourned.